Welcome back to the podcast. I'm Dr. Khan, and today we're diving into one of the coolest glitches in the human wiring system, visceral afferents and referred pain. Dr. Sarah, I was looking at a case this morning, a 65-year-old guy crushing chest pain, but he's rubbing his left arm and his jaw. He's convinced he just pulled a muscle, but we both know his heart is screaming for help. Why does the brain get so confused?
It's a classic presentation, Dr. Khan. To understand it, we have to look at the neuroanatomy. While the autonomic nervous system is primarily a motor pathway, we have these hitchhikers called visceral afferents. These are sensory neurons that travel alongside autonomic fibers to bring information from our internal organs back to the central nervous system.
I love that term, hitchhikers. It's like the sympathetic nerves are the main highway, and the sensory fibers are just jumping in the passenger seat to get a ride back to the spinal cord. But Dr. Sarah, why does this matter clinically? If the heart is the one in trouble, why aren't the nerves just telling the brain, hey, it's the heart?
That's the high-yield question for any board exam. The reason is convergence. Most of the time, our viscera, the internal organs, don't send much information to our conscious brain. We aren't aware of our gut moving or our heart beating. Because of this, the sensory pathways for organs are relatively quiet. However, the sensory pathways for our skin and muscles, the somatic pathways, are very busy and well mapped in the brain.
So it's like a busy 10-lane superhighway for the skin merging with a tiny dirt back road for the heart, and they both end up at the same toll booth in the spinal cord.
Exactly. Specifically, they converge in the posterior gray horn of the spinal cord. When those visceral pain signals from a myocardial infarction, a heart attack, hit the spinal cord at levels T1 through T4 or T5, they excite the same second-order neurons that normally carry signals from the T1 to T4 dermatomes. And the brain, being a creature of habit, assumes the signal is coming from the high-traffic area, the skin of the chest and the left arm. It's a literal case of mistaken identity. This is why our patient feels pain in his arm and jaw, even though the fire is in his chest. But Sarah, let's get precise for the students. How do these fibers actually get into the cord? For the boards, remember the pathway. The visceral afferent fibers leave the organ, travel through the autonomic plexuses, and then reach the sympathetic trunk. From there, they pass through the white rami communicantes to reach the spinal nerve, and finally enter the posterior root. Their cell bodies are actually located in the posterior root ganglion, just like somatic sensory neurons.
That is a huge distinction. Students often think the cell bodies are in the sympathetic chain, but they are in the dorsal root ganglion. Now, why does this matter clinically when we talk about something like the gallbladder? My patients with gallbladder issues often complain of pain in their right shoulder. That's nowhere near the liver.
That's a beautiful example of referred pain involving the diaphragm. If the gallbladder inflames the peritoneum covering the diaphragm, the sensory signal travels via the phrenic nerve. Since the phrenic nerve originates from spinal segments C3, C4, and C5, the brain refers that pain to the C3 to C5 dermatomes, which cover the shoulder.
Right, the old saying, C3, 4, and 5 keep the diaphragm alive. If you're the doctor of choice in a busy emergency department, you have to be able to map these referred patterns instantly. If you only look where the patient points, you're going to miss the actual pathology.
Spot on. We should also mention Hilton's law here. It states that a nerve supplying a joint also supplies the muscles moving the joint and the skin over those muscles. While it's a somatic rule, it follows that same logic of shared wiring that clinicians use to track down the source of pain.
It's all about the neighborhood. If one house is on fire, the neighbors are going to feel the heat. Now, we've talked about pain, but visceral afferents also handle reflexes that we don't feel, right? Like blood pressure?
Yes, those are the quiet afferents. They travel mostly with parasympathetic nerves, like the vagus nerve or cranial nerve 10. They monitor things like chemoreceptors and baroreceptors. For the exam, distinguish between visceral pain, which usually hitches a ride with sympathetics, and visceral reflexes, which usually travel with parasympathetics.
That's a golden nugget right there. Pain goes with the fight or flight team, sympathetics, while routine maintenance and reflexes go with the rest and digest team, parasympathetics. So when my patient has a crushing MI, those pain signals are screaming up the sympathetic pathways into the T1 to T5 segments, and the brain thinks the arm is being crushed.
Precisely. And because those segments also provide some innervation toward the head and neck via the sympathetic chain, the pain can radiate to the jaw. It's all about shared segmental levels.
So to wrap this up, why does this matter clinically? It matters because visceral pain is a liar. It rarely tells you exactly where it's coming from. It speaks in the language of dermatomes.
Exactly. If I had to give one takeaway for the boards, referred pain occurs because visceral sensory fibers and somatic sensory fibers converge on the same secondary neurons in the dorsal horn of the spinal cord. The brain interprets the visceral distress as coming from the somatic dermatome associated with that spinal level.
Brilliant. Know your dermatomes, know your hitchhikers, and you'll be the doctor who actually solves the mystery. Thanks for joining us, Dr. Sarah.
Always a pleasure, Dr. Khan.